Well, I think this is going to be interesting and traveling as well. Good concept. Let us welcome our chairperson, Dr. Lalit Verma. Dr. Sir is
Excuse me.
let us welcome our panelists, Dr. Sobhit Chawla is there. Dr. Munawar ma'am is there. You can come in front. It'll be nice. Okay. And Dr. Mallika Goyal ma'am is there. Not yet. Dr. Arvindam Maiti will be there to moderate the session with me, and we have a few interesting topics, the five topics to debate on. The first topic, let us start the session. By the time everyone joins in, the cruise will start and it will start to sail. And let us call upon the first debaters. The first topic is heads-up surgery versus conventional ear surgery. Dr. Prasad Mule versus Dr. Devdulal Chakravarti. So let us first call upon Dr. Prasad. Dr. Prasad Mule will begin the debate.
They are waiting for you. Yeah, there is two. Okay. Yeah, there is two. One is on this is dating number one.
Normally.
So we are waiting. I just saw your
This is just to say that each debater has 4 minutes to debate, and then maybe rejoinder if our panelists allow, and then the final comments from our panelists. This is the format of the debate, and 4 minutes for each speaker. Please stick to the time so that everyone can enjoy the cruise.
Okay, guys. Good afternoon, friends. Yeah, I think we are ready.
Yeah, please start.
Okay, thank you. So, friends, there is a debate that is going to be whether it's 3D heads-up surgery. Is it the need of the hour? Or it's just a privilege. Let us move through this presentation. One thing one needs to remember as a man of science is change is the only constant thing in life, and you cannot live with what is happening today. See, this is the evolution of visualization technology. Way back in the 80s, when we saw people winning the World Cup, this was the TV on which we saw. We did enjoy. We had that thrill of winning for the World Cup for the first time. But technology now has moved, and now we can see on such a magnification screens where it is so immersive that you can pick up one of your friends sitting in the auditorium or the stadium. Now let us see, this is the thing which I was operating about 5 years back, and even now I operate in the second theatre, and this is how now I operate. So is it just a fashionable matter of fashion, or does it really offer certain advantages over it? So these are the advantages which I will be delving upon, the points, scientific points, why 3D surgery is the way to go ahead in future. These are the advantages. So the basic advantage is the magnification. It offers you a magnification which is 24 to 40% more than what an analog microscope can offer you. So that means anything you see in a magnified way, you are going to deliver better. This is what we saw on light microscopy. We were thrilled. When we started seeing on a transmission electron microscopy, we could see better, and this is what you see today. So it is up to you to see what happens in a magnification. Look at the phenomenal magnification at which membrane peeling is being done on a macular surface. Could you really imagine it over the previous analog microscope? No, because it compromised on the field of view as well as the depth. This is another video again to show you the magnification, phenomenal magnification which it allows. And magnification, remember, it offers you the best of the viewing. This is you can see vitreous based shaving which is being done under the direct visualization of a microscope, and you can actually see the individual vitreous fibrils which was never seen on an analog microscope. Now this is a case of a ROP, stage 4 ROP, where I am dissecting the membranes and look at the. This is such a small globe where you have almost 1/3 of the vitreous being cavity being occupied by the lens. This is the membrane dissection which is happening at the extreme periphery, and look at the magnification at which it is happening. This is what I am feeling. This is a bimanual dissection being done under a 3D surgery. So ROP surgery is the pinnacle of a surgery which any vitreoretinal surgeon feels. Now, regarding the field of view, it is 5 times better. It is important in such complex pathoanatomy because at the same time you need a complete viewing of the full view, so that wherever the attachments of the membranes are there, the tentacles of the membranes can be picked up, so you do not create an iatrogenic break. And this is a giant retinal tear. This is a case of it. Giant retinal tear. Again, look at the phenomenal field of view which you are getting and the magnification. You can actually see the unrolling and the opening of the funnel which is being done, and under a single view. You don't have to move your microscope here and there. Another case of a ROP where you need multiple, you have tentacles where you have to identify. Now look at that particular tentacle which was present. Had I pulled it up without knowing it, I would have caused an iatrogenic break. And all this at the depth of perception which is 11 to 42% more compared to the microscope. Now look at this. This is what is there. Now you look, this is a ridge in the stage 4 ROP which is moving from anterior segments. From the anterior ridge, the membrane was extending up to the posterior surface of the lens. And look at the phenomenal magnification and the depth which this machine is allowing you. So now coming to the color filters, yes, in a certain cases, if you have filters like this, it draws down the red color which comes in the way of your viewing, and this is how additional advantages is. Now this is another case of a filter where membranes, when it is not visible in spite of staining, use a proper filter can help you visualizing the membranes more better. And all this happens at an illumination which is 1/10 of an illumination which we use in cases of analog microscope. Digitalization of the images has added certain things. So when you are shooting this particular image in a crib, the dark valley cannot be picturized. If you overexpose it, it will be all blinded out. But if you digitalize an image, this is the beauty of it. And same thing, digitalization has facilitated all these cases. Same thing, the color tone mapping which is possible because the image which is shown to you is after processing and it's a digital. Importantly, every one of us has to age, and most of us, the vitreoretinal surgeon, the common professional hazard is a back pain. And so this will be an additional plus. If you have a postgraduate institute who are learning, everyone can have the same image and can learn simultaneously. These are some of the atypical VR cases which I am just running through it because of want of time. This is another case. So this system was designed basically for vitreoretinal procedures, but does that mean it is blocking one of my theaters? No. This is the article which we published in AIOC in July 2021, where we showed the utility of this particular system even in anterior segment. I'm just coming to the conclusion, and it showed that anatomical and physiological results are similar in all groups. In regards to safety, 3D surgery is as safe as an analog microscope. Surgical time same after the learning phase. Time lag and learning struggle which people talk about is only during the learning phase. But if you look at the field of view, depth perception and color contrast, 3D surgery scores over this. So these are some of the challenging. This is a phaco in grade 5. I just run through this particular video I just show where you need a bigger field of view, where I am going to do a traumatic cataract surgery along with iris repair. I cannot forward it from here because of the thing. And you can see I have retracted it with the iris hook. I will be doing a phacoemulsification and then I will be doing an iris repair. And this is the end result of this particular patient. So even such complex anterior segment procedures, even the simplest anterior segment procedures like pterygium, spins, Hammond walls, trabeculectomy, all can be done. And look at the wealth of the literature which you have in favor of this. So to summarize, 3D digital surgery is here to stay and is made important because of high magnification, enhanced image, increased peripheral acuity, low illumination, and better light mapping. So if you see better, you are going to deliver better. So friend, it is up to you to decide whether you would like to gaze at the stars without a microscope, with a simple telescope, or with today's reflecting and refracting telescope where you can pick up an insect crawling on the surface of a moon or a star. And simple safety and predictability, as we have learned during Corona times, it offers you better. Economics, well, most of the people like Dr. Satya has locked dollars inside his rooms rather than getting unlocked it, use it for the proper thing, because if you get early advantages, you are going to be benefited in a business setting in a bigger way because you are doing a 3D surgery. So it's time for you not to be amongst the late majority or laggards, but initial adapters, you will get the benefit of it. Thank you once more.
Thank you, Dr. Prashant. And we will call upon Dr. Debula Chakraborty for his talk. And then we will move to our audience and, of course, to our panelists that I will ask to take their opening points.
I'd like to thank AIOC for this kind of opportunity, Dr. Larry Verma sir, my friend Dr. Aniruddha, Dr. Siddharth Ghosh, for having me here. And I'm on the opposite side of someone I really like and love, Dr. Prashant Bhavan. Wouldn't like to really talk, opposite to what he has spoken about, but I will, in any case, I will speak about my beliefs and what published literature has to say. So I will not die without reading this. I have no financial interests, and we will be enumerating some of the propagated myth and do a reality check on the propagated themes. Remember Segway? All of us have probably tried this out at some point in life, and this was an abject failure, so to say. And this is what this company is doing now. It is redefining mobility with the help of bicycles. Some of them are, have the battery packs. Let's look at this, the ubiquitous insulin syringe. So it was thought to be something cumbersome, something pokey, something not good. And so we had, for a little while, we had Exubera. And, it died its natural death because people are not willing to take it. You have to carry something like this big, and this was not really convenient. And we were back to using our insulin syringes, and now we have nice pens which you can just carry in your pocket, and that's the end of the story. So now let's look at standard operating microscopes versus 3D heads-up display. Potential advantages. However, most of these potential advantages claimed by the 3D heads-up display are propagated claims. Who says this? I don't say. Ophthalmology Retina 2019. Let's look at some of the propagated myths. 3D HUD can improve surgeon ergonomics and decrease fatigue. This is what the companies tell us. But look at the reality check. This is from Indian Journal of Ophthalmology. Operating on 3D is associated with 5 to 10 degree of face turn to visualize the skin. So imagine, doing your surgery whole day like this. If you have 5 cases, VR cases, I'm sure you will have to have a sprain somewhere. So maybe your back will be okay, but you will have something here. Look at this, pathetic. Is this a ergonomic position for a VR surgery? Definitely not. That runs into maybe an hour or so? Definitely not. So with time, we have very senior surgeons. I have seen many of my teachers doing surgery sitting straight. Madam is here, and I tried to emulate her, and she always sits straight. And those were the days with 400 cut rate cutters that madam used to do surgeries for 2 hours, and we would imagine like how she could do it without absolutely any issue. So basically, this is what is important. Now you have extendable oculars. If you cannot really sit straight in certain situations, then you can have extendable oculars, and this mitigates your pain to a large extent. Next, digital filters enhance visibility. Let's look at what literature has to say. Blue filters shows vitreous better when tagged with triamcinolone acetonide. Who says this? Indian Journal of Ophthalmology, Ophthalmology Retina. Color filters reduce the quantity of dye exposure, do not eliminate. Next, let's look at the next myth. Lower ND illumination may be potentially, something that reduces macular phototoxicity. Reality check. Significantly longer surgery time with 3D. Energy, as we remember from physics, is power into time, so it's the same story. Time of exposure is higher, so light energy delivered is the same or more. Next myth. 3D might facilitate shortened procedure times. What does published literature says? So I think this is acceptable published literature. Macular peel time significantly longer with 3D. Critical surgery time significantly longer with 3D. So let's look at the next myth, better teaching tool. So let's look at this, analog image. Is it too bad? And how about this? I can teach my students, I can teach my fellows with, this quality of image. And, I think you can do a fair job with it without having those gizmos around. Other issues, assistant discomfort. We did use, 3D surgery for a while, and our assistants didn't like it at all because they had to, turn around to this or that position and, do the surgery. So it was not comfortable. Then you have frequent focusing that is necessary, disturbance by media opacities, surgeon headache and nausea after prolonged use. Not my words, please. And surgeons make slower moves, more conservative movements. Other issues, OR logistics. The whole OR goes for a toss if you have to, arrange a 3D surgery. That's what we've seen. Higher rate of malfunctions, challenge to give the anesthesia provider adequate space. I see Sobit sir, agreeing to me, and it's my good fortune. Latency in 3D visualization. This is something that has been, partially, taken care of, I would say, subsequent to these publications, but it's not as good. So ultimately, what you have is more complications. Iatrogenic breaks, my God, 16%. I thankfully most of us don't have 16% breaks. Free flaps, 17%. Just imagine, all macular surgeries would go for a toss. More cases of retinal detachment and postoperative PVR. Limitation of this technology includes the cost of the device. But it's not a case of sour grapes for us. We see 15 lakh patients in a year across our 18 branches, and we do 1.75 lakh patients in the Retina OPD, and we do more than 6,500 VR surgeries. Leave aside, SORs and, injections and stuff like that. So it's not a case of sour grapes. What we did instead, we established 2 more branches in the last 2 years rather than investing on 3D, surgery. And where did we invest? In peripheral places which are unserved. So you have, something that's affordable but not really good for us. Surgeons reported ease of use was significantly higher using standard operating microscope compared to 3D HUD, and you have this publication here. So to conclude, newer systems may be appealing, but they might not always be useful or necessary. Thank you for your kind attention.
Thank you, Devdulal. That was great. And let us just have a show of hands from our, esteemed audience who would like to go with Dr. Prashant. Just a raise of hands, show of hands. Okay, 2 hands there. A cost. Okay. Dr. Prashant, the cost. I think
it costs you around 1.2 or something like that, 1.2 CR over the existing microscope.
Okay.
Over the existing microscope, I said.
Right. And I think rest of all are with Dr. Devdulal. Is it? Okay. That's great. So yeah. Right. Yeah. Now we'll take that opinion from our esteemed panelists. Yeah, sir.
See, having used both RTO and Ingenuity in my OT, and I used it for most of the cases. Yes, I have not done ROP surgery on it because I don't do ROP surgery. That my colleague does. I have come back to the conventional viewing systems. I felt the effort, the cost, the ergonomics, and I would rather save my neck than my back. Back you can cure with a lot of exercises, but once the neck goes into a sprain, it's an issue. So my thoughts and about the depth, I have my reservations, especially if there is a dense vitreous hemorrhage. I find non-contact viewing systems, be it Biome, Resight, any, with the plethora of lenses, much better. That's my take on it.
Madam, yours.
Yeah, I use both of them, but I probably would be using the Ingenuity if I did not have to do very fine work, because I am probably still not comfortable doing that. I would use it maybe a case under GA where I feel free to curse everybody.
And what
Yeah,
about
it has
training,
its point,
what about
but,
training fellows?
Training fellows, see, we don't have an audience in the OT. We have one assistant who assists through the side tube. So, I mean, as far as that is concerned, I don't use that as a reason. Yes, you see it big, and because those are newer microscopes, your video quality, it looks better. I have used it. It has its plus points, but unfortunately, I don't like that 5 to 10 degree what Debdulal spoke about. Touch wood, till now I've never had a problem with my neck, but there are days when I have long cases on Ingenuity that my right side bothers me, because in both our theaters it is on the right side. I think it has its points. There are people who love it. I use it because it's there and I don't want to be left out. So, but yes, every OT I will do one case on Ingenuity, just to make sure I'm going with the times. That's all.
That was really great. And is anything else?
As far as been training fellows now for 25 years, I felt training them on a non-contact system or a direct view, even a contact system, is much better and easier than training on. I would not risk them trying out on a 3D.
Right, thank you. So let us go to the next topic. And the next topic is SFL versus iris claw lens. And each debate would be for 4 minutes. Let us first call upon Dr. Manav Jyoti Varman, and he will be for iris claw lens.
So thank you, thanks Dr. Anuruddha and all organizers for giving me the opportunity. So I will speak on the support of iris claw lens. Okay. Okay. So FAK correction. So it is definitely all of us know the value of the FAK correction, how it works. So lots of options we have currently: anterior segment intraocular lens, then scleral fixated lens in different
Manav, yeah.
Scleral fixated lens in different fixation pattern like suicidless or suicide, and then retropupillary iris claw lens and glasses, and also there is touching on lenses for the pediatric population. So just a small video. So this is a case done in the community OT radar. You can see a complicated FAK radar. You can see the iris pupil is quite distorted, and anterior vitrectomy being done by anterior segment surgeon, and the iris claw lens is being placed. So this is really people will say this is not a good surgery. That pupil is damaged and lots of complications you can see, but at least the iris lens was given in right time and in the same setting. That is a good thing it was done in this case. So retropupillary iris claw lens, it encapsulated with iris tissue. Insufficient capsular or jonular support, we can put iris claw lens. Its design may be plano-convex, biconvex, or convex or concave. Optical diameter may be from 5.4 to 8.5 overall diameter, and it comes with from +2 to 30 diopter power. So what are the advantages? it is minimally invasive. So we can do in the same sitting, all of us know. So no specialized training is necessary, so any anterior segment surgeon can do this. So a short recovery period, though some studies show that recovery period may be slightly longer than SFIL, and high success rate, and less risk of corneal decomposition and damage to the angle. And outcome analysis, iris claw lens versus ACIOL, comparative visual outcomes at follow-up. IOL sizing is proper. Lesser incidence of postoperative iritis, IOP spike, and endothelial cell loss. And while comparing with SFIOL, it's comparative visual outcome at follow-up. Safe in pediatric patients. It can be combined with penetrating keratoplasty. It's time saving, that is the most advantage of this. Safe in eyes with poorly dilating pupils without other iris deformities. But however, it's limited utility in cases of severe iris damage. So disadvantages, in the best of the hands also it may cause ovulation of pupil. From 5% to 33% cases have been reported, and spontaneous inflammation may occur. There may be pigment dispersion. Cystoid macular edema may happen, but this may be a secondary complication of cataract surgery rather, and iridial synechiae may happen. So while coming to disadvantages of ACIOL, raised IOP, hyphema, peripheral enterosynechiae, iridocyclitis, and sizing may be a common disadvantage of ACIOL. And SFIOL, retinal detachment, choroidal hemorrhage, discentration and tilting, suture erosion, haptic erosion, long learning curve, specialized equipments, and limited resource. All this, there's a major complications may happen with SFIOL. So though I'm a beard surgeon and doing lots of SFIL, but still I accept all those points in favor of iris claw lens. So my take home message is iris claw lens is safe for aphakia correction with limited resource or time, and good anterior vitrectomy and maintenance of the pupillary structure or the pupillary margin is important for good outcome, and long-term visual rehabilitation is compatible with SFIL lens. All the cases are not as bad as I have shown in the video. So thank you.
Thank you, Dr. Manav, and thank you for sticking to time. That was really good. And let us now welcome Dr. Aditya Kelkar, and then we'll take comments from our panelists.
Thank you for inviting me for this debate. I'm going to talk about SFIOLs, why not? So if Dr. Burman was a movie director, his movie would be 1 in 3, which means he would choose all the time only one heroine for all the movies that he has. But probably he ends up with something like this. And I happened to see this patient recently. You know, she was doing very well till she met with an accident and had to get operated in Guwahati. And then the patient followed up with me and I did the slit lamp examination. Also, I happened to see another patient, and that movie was not 1 in 3, but it was 3 in 1. This patient had corneal decompensation, ovalization of the pupil, and also the detachment of retina. So I don't know whether it is 1 in 3 or 3 in 1, whatever it is. I prefer SFIOL, and why not? Or I should say, I prefer SFIOL, and why yes, I will tell you why. So if I was the movie director, I would definitely not stick to only one. I have my angels, and why not to give them their talent a chance? So you have all various options when you want to do SFIOL. You can do a Canabrava, you can do Yamane's IOL, you can do Geber-Sheriat's technique, or you can do a technique by Dr. Nivian's scleral tuck IOL. So you have all variety of options to suit the movie that you want to direct. Now, I thought he is not reading between the lines. When we published the article comparing SFIOL and iris claw IOL, yes, both look the same, but same can be different. And what is the difference is the ovalization of the pupil. Also, if you want to try something very innovative and want to give something that is really necessary for the patients who have unacceptable astigmatism, with the newer techniques of Canabrava, you can even do a toric IOL with the same scleral fixation technique. All other techniques that we have tried to compare, Geber-Sheriat's technique, Yamane's technique, and other SFIOL techniques, and we found that various SFIOL techniques are equally good. So with that, I rest my case. Thank you.
Thank you. That was great. Again, perfectly on time. And let us take comments from our panelists. Madam, will you begin first? Yeah.
I don't do SFIOLs or iris claw myself, but I just wanted to ask Manav. Sometimes we are worried about dilating these patients. Which is the patient we should be worried about, and how would you identify that patient? Sometimes we are worried about dilating patients with this iris claw lens because it's known sometimes to dislodge. So, how do we recognize those patients?
No, actually, to be very honest, I also not do too many iris claw lenses. Iris claw lenses are mostly done by anterior segment surgeons. But whatever cases I see, dilatation is not an issue if the lens is properly fixed.
So, how do you identify that this lens is not properly fixed? I should not
if the
dilate
pupil is
it?
no, it depends on the pupil. If the pupil is distorted, iris tissue is damaged, then there is less chance of proper dilatation. But usually it dilates. And so it is a easy technique. It is done by different grades of surgeons, from the very naive surgeon to very expert also. But in the hands of experts, definitely it gives good results.
No, if you have to identify which are the iris claw lenses which may get dislodged when you dilate, that is if you look at the slit lamp, if you see that there is iris atrophy or thinning of the iris in the area where it has been tucked in, and eyes which have an ovalization, those are the eyes. The reason ovalization predominantly happens is because the tucking in of the iris is not proper and not well centered. Those eyes and the eyes where there is a subsequent long iris atrophy in the area where the tuck has happened, these are the eyes where a dislodgement can happen. And to be honest, I also don't prefer iris claw lens if this is a debate. I would, like Aditya said, definitely go for a glued-IOL or an SFIOL. These cases also somehow tend to probably have more pigment dispersion, and there is always a long-term risk of a CME which can occur. You've got something which is irritating the iris constantly, and there always can be a potential for a low-grade inflammation which can occur in these eyes. So given a choice, I probably will always go for a glued-IOL or a SFIOL.
I think the most important thing is when you're doing a complex surgery, a posterior segment surgery, you should not get over tempted to do your secondary implantation at the same sitting, but let the eye stabilize for a couple of months and then do it. I have seen complications both with SFIOL, whether it be vitreous hemorrhage, peripheral tears with RD, or persistent cystoid macular edema. With retrofixated iris claw lenses, my only issue is that I've seen some of them dangling from one of the enclavement sites, and then it's a messy job again taking. So if we look at anatomical and physiologically, SFIOL is a better technique overall, and but one should not be tempted to do it at the same sitting where you have an aphakic eye and you can always do it as a secondary procedure.
Thank you, sir. Let us go ahead with the next topic, and the third topic is scleral buckle versus PPV as primary wear surgery. And the first debater on this topic would be Dr. Mahesh Uparkar, and over to Dr. Mahesh. And Dr. Maite had something to say on this SFIOLs. In the meantime,
I just wanted to add, once this iris claw is enclaved, it is very difficult that it will dislodge. Only a few cases does. In that cases, like the enclaving is not done properly. Actually, it is just the opposite. Once it is enclaved, it is very difficult to disenclave. And it should be just a mild tuck. If we push very hard, then only we lead to ovalization. Otherwise, ovalization doesn't happen. Yeah, that's what I told. It is very difficult to explant.
For explantation, you need to cut one side. Cut the haptic. One haptic, if you cut, is off. Now the clip will not be there. And yeah. No. If you dilate the pupil and cut one haptic, it comes off. You don't need to entangle that. And one more thing is enclaving. You have to use the enclaving rod, not the Sinskey hook. You have to use the enclaving rod. And the pupil should be small. When you are enclaving, you have to put intracameral pilocarpet, clear all the vitreous in the anterior chamber, and then you have to enclave that. And that's a good procedure for anti-segment surgeons and easier also. The same sitting, we can finish both, and we will not have to face the patient embarrassingly the next day when we have to tell them we could implant a lens and we might have to do a resurgery. And then, sir, again, how about oscillopsia, sir? With iris fixated IOLs, do you see any oscillopsia? In vitrectomy patients, it has happened. Not in.
I think we will have this discussion later on. We need to move on. Mahesh.
Thank you, Anirudh, and thank you for inviting me for AIOC. This is a wonderful time to be on the cruise, and for me to discuss and debate with Dr. Shubhendu. So we have these newer ways of operating, and as time goes by, we know that older techniques fall out of grace. But some techniques, as I said in my first slide, are always evergreen. And even though you may like the new techniques, the efficacy and the flashiness, which Dr. Shubhendu will talk about, I'm here to advocate why we should stick to some of the older techniques that we have, especially when you compare it to vitrectomy, because the clear advantage of preserving the crystalline lens is something that will give a very nice vision for the patient post-op. Advantage of not doing any positioning is something which all of us in our OPD would have noticed, patients complaining of backache, shoulder ache, headache, and that is something you can easily avoid with a buckle. Effective, earlier, complete rehabilitation. I think those who have done buckles and those who do buckles know how exactly the retina settles so beautifully after surgery. And given that the anatomy, I'll speak about this better, about in the next slides. So some of us would be hesitant to do a buckle, and that would be because we have gone to this era of micro-incision vitrectomy where you don't touch the conjunctiva at all. So tissue dissection is an art which has been lost. The scarring kind of hinders us from doing the buckle. There could be a squinting, asthenopia. Pressure changes are common actually in both vitrectomy as well as IOP changes in buckle. The non-seeing part of buckle where the drainage can lead to choroid bleed is something which is always on the back of our mind, that this is something of a dreaded complication. But with experience, you do get around this. And the need for second procedure, especially if there is PVR which is set in, then the risk of doing a second procedure is a slightly disadvantage of a buckle. But given that we have moved on to the era of 27 gauge vitrectomy, I was surprised to note that the debate still rages on, that we still are talking about buckle versus vitrectomy. And as you can see in the slide below, in 20 years, the publications of buckle versus vitrectomy have actually kind of increased. To rest my case, I would like to kind of quote two important publications, which are the systematic reviews and the meta-analysis. In both of these, in the top one, you can see that a large number of eyes, 7,000 and more, and then in the lower one, nearly 16,000 eyes. Both of them advocate that there was no significant difference in the final visual acuity, which is what we are looking at. Also, the risk of macular edema, complications, ERM is much higher in a vitrectomy patients. And the second one, this is from, I think, Canada, the second one, the pars plana vitrectomy versus buckle. It shows very clearly that the preservation of the lens gives a distinct advantage in terms of visual acuity to patients who are undergoing buckle. And the final reattachment rates were actually similar between the two types of surgeries, with a lower incidence of iatrogenic breaks and cataracts. And while vitrectomy, there was an advantage because it's done under vision, therefore the risk of choroidal bleeding, detachment, and residual subretinal fluid was much lesser in the case of vitrectomy. So to highlight my point, if you're an award-winning vitrectomy surgeon, you have excellent 20 surgeries in a day, then you would rather do a vitrectomy. Like Dr. Boral always does vitrectomy. But if you have a young adult, you have time on your hand, and you know that the patient does not have a PVD where you are going to struggle with the posterior vitreous detachment induction, then I think these are the distinct advantages where you would like to do a buckle. I'll rest my case by showing a small video where for those
would like to know, this is a chandelier buckle where I'm doing a cryo to the brake. So gradually you see the cryo around the brake, and it's a surgery done under vision without need for shifting to an indirect ophthalmoscope in the OT setting. And once you get cryo all around the brake, then you are secure, tightening the buckle. But before you do that, you would like to drain a small puncture in a single sitting. Steady pressure will allow the fluid to settle and the retina to settle and the fluid to drain. Tighten the band and the buckle element. Recheck. What you have done is the brake is on the buckle. And if you're caring about sutures, you can go ahead with a glue. Thank you so much.
Thank you, Dr. Mahesh. Let us call upon Dr. Subhendu Boral for his debate.
Good afternoon, everybody. Generally, I am trying to avoid arguing with others, but unfortunately, I have to participate in this retina debate. That what should be the primary treatment for retina detachment? Is it PPP or scleral buckle? I'll talk on in favor of personal vitrectomy. Basically, what is the we should know what is the available treatment option for retina detachment. It's a pneumoretinopexy. Lot of encouraging results are coming with pneumoretinopexy other than that vitrectomy or scleral buckle surgery. Second option is scleral buckling. Third is partial vitrectomy with gas or silicone tamponade. Now, our debate is on scleral buckle versus partial vitrectomy. First, it is my honest confession, I am not in favor of scleral buckle surgery as a primary mode of management in retinal detachment. I will tell you why. Think about the steps of scleral buckle surgery. It is either you have to use segmental buckle, 276 to 279. Generally, we are using it. Circumferential belt buckle, that is the encirclage. Number 3 is transscleral cryoretinopexy. And fourth is conjunctival 360 pyotomy closure. I will talk on the negative sides of the scleral, all the steps. Like segmental buckle has segmental scleral invagination that will increase the irregular astigmatism postoperatively. Second thing is circumferential belt buckle, the encirclage that is postoperative myopic shift is like an issue. It will cause globe elongation. And chance of globe perforation by the needle in high myopes during the putting the scleral buckle. There is always chance of globe perforation if you are operating on the thin sclera in case of high myop. Chance of anterior segment ischemia, it is more in diabetes because of peripheral ischemia that you have already you have missed, and postoperatively patient will come with all the symptoms of peripheral painful, almost painful eye with peripheral with anterior segment ischemia. Third thing is transscleral cryoretinopexy that will induce more inflammation and release of more RP cells, inflammatory mediators, as in cases of multiple tears, not in single tears. That will induce more PVR changes. So conjunctival 360 pyotomy also it cause postoperative discomfort if sutured, but nowadays we are using glue also to close the pyotomy, so the conjunctival apposition with the glue. So the other disadvantage of scleral buckle surgery cannot manage periretinal PVR membranes or macular pucker situation, or only you can do it up to PVR C2, that some says up to C2, beyond C2 it is not possible. So whereas PPB is for all. So the current indications for scleral buckle surgery for me, it is a partial, subtotal or total fresh retinal detachment in a young phakic patient with a single 1 or 2 breaks. So I want success on table. So on table success is the prime importance. Basically, I want a good sleep at night. So the fluid will dissolve by its own. But sometimes what happened, tear will just, the posterior margin of the HST is just posterior to the buccal indent. The fluid vitreous will cause seepage inside the subretinal space that will cause persistent fluid in the macula or recurrence of retinal detachment. So beauty of MIBS, visualization and the cutter technology as well as the illumination options that will predict more. It is more predictability after wear surgery. So it is the primary mode of treatment should be for all situations except young phakic patient with 1 or 2 breaks for me. So this is my opinion. So I should not argue with somebody's own thought. This is I think universally we are accepting all. Thank you.
Thank you, Shubhendu. That was really good. And let us take comments from Dr. Souvik Chawla.
I think Subhendu is himself summarized. Today, all of us believe that scleral buckle is best in young phakic patients with breaks which are amenable to a reasonable scleral buckle, not very posterior tears. But at the same time, I would like to say that the line, I want success on the table, should not outweigh philosophically us giving the advantage of a buckle to a patient where a buckle is amenable and can take care. Because some of the recent publications also say that if you have a recurrence, it is much easier to fix a buccal recurrence by a vitrectomy than a repeat vitrectomy if you have a recurrence. So this is in one of those publications which was earlier highlighted in the last talk.
Thank you. Madam, you're...
Yeah, thank you for a nice debate. Probably I have grown up in the scleral buccal era. And definitely I would say our indications for doing vitrectomy are more than they were earlier. But like you mentioned, there are cases where I think everyone would agree that we can still sleep well at night if we do a buccal. And a nicely done buccal. Sometimes when we highlight complications, most of them are if it's not done properly. There is a nicely done buccal. You can do it in 45 minutes if you don't depend on somebody else to do things for you, including drainage. And all you need is 2 good eyes, good stereopsis, a good indirect ophthalmoscope, and your clinical skill. You don't have to search, you don't have to rely on technology to find that break for you or do 360-degree laser, because even a pseudophakic eye, you may just have a little sinus at the top with a small horseshoe tear, and you do a non-drainage buccal and next day patient is flat. So all said and done, yes, our indications are changing. Buccal still has a role, especially when we are doing pediatric eyes with cases like FEVR and some cases of peripheral ROP, when I think most of us would be very hesitant not to put a buccal. But otherwise, well argued, both of you.
Thank you, ma'am. So let's move on to the next topic, intravitreal TPA versus subretinal TPA and subretinal hemorrhage. There is a lot of controversy. Some prefer to give subretinal and others prefer to give intravitreal. So let's hear it from Dr. Satyaprakash Tiwari on intravitreal TPA and subretinal hemorrhage.
So good afternoon, all of you, and thank you, Mati sir, for inviting me this talk. Intravitreal or subretinal TPA, it's a debate in situation like many a times we do see huge blood behind the retina, especially over the posterior pole behind the macula. And common causes, as we know, that ARMD, idiopathic polypoidal choroidal vasculopathy, then RAM, trauma, high myopia, angioidistics, and all these ocular histoplasmosis. Why to displace the blood? Significant blood in subretinal space for a longer period would lead to degeneration and scarring of photoreceptors, and ultimately reducing the prognosis in that eye. So there are multiple options to displace the blood out is available, and the more convenient and easier way is to just use a gas, and that is a very good option if the blood is a little bit fresh and it is not clotted. Duration of 1 or 2 days blood, it just get displaced with just giving injection, and we don't need to do much. But many a times we do see patients coming later on with a duration of 1 or 2 weeks, and the blood is large and it is clotted, and many a times if we inject gases it may not displace. So here comes the role of subretinal TPA, intravitreal TPA or subretinal TPA, or sometimes surgical removal of the blood clot also. So why to give intravitreal TPA? See, intravitreal TPA is a very simple technique. We all of us we are giving injections right and left intravitreal, and we know how to inject in the vitreous cavity. There is no special technique training or skill is required. There is no special equipment or surgical setup is also required to give intravitreal. It is minimally invasive, just a 30 gauge needle, and we just give it. It is a quick procedure. It is also cost effective, that we are just having the minor procedure charge and the drug cost, and we are not doing a major vitrectomy surgery, and relative accessibility may facilitate earlier intervention. Like it can be done in a medical retina setup also, where there is no facility of vitrectomy is available. We just need to inject in the vitreous cavity. The risk of complication is very low as compared to that subretinal TPA, where we do pars plana vitrectomy and get a lot of complication. This was a published prospective trial of subretinal TPA versus intravitreal TPA, and we can see the results that the outcome, that displacement of the blood is 97% in intravitreal group and almost 100% in subretinal group. That is not at all statistically significant. And the most important point to remember, that in few cases where we do not get displacement of the blood by use of intravitreal RTPA, are those cases where the blood is very thick clotted and the retina is already scarred, and the prognosis is anyway very poor, and the presenting visual acuity was very less. So anyway, in those cases, if we do a very big surgery and displace the blood, we do not get any significant advantage in terms of vision. Literature review of these TPA injections also shows that the outcome is equally similar in both the groups, but the complication rate is very, very high in case of subretinal TPA in with vitrectomy. These are some of the cases of use of this intravitreal TPA, and there was a again published study in Retina Manchester protocol, which says that if we see a patient of large submacular bleed, we just need to inject C3F8 along with this TPA, and we wait for the displacement of the blood, and if it doesn't displace, then vitrectomy and subretinal TPA can be used as a secondary procedure. So this was one of my case, injected just TPA and C3F8, and later on anti-VEGF Pagenex, and it was IPCV, and the blood displaced with just intravitreal TPA. So with conclusion, intravitreal TPA is safe, easy technique. It is a minor procedure, and suppose if we are having a patient old age, high diabetes and everything, and for doing vitrectomy we need to get lot of clearance, and the surgical procedure will delay, and that will hamper the prognosis. The cost is less, the setup needed is very less, and this that outcome is similar. So my take is that we should always go for intravitreal TPA for displacement of blood rather than going for a bigger surgery and putting subretinal TPA. Thank you.
Thank you, Satya Prakash. Let's hear from Dr. Mudit in favor of subretinal TPA.
I think Dr. Satyaranjan has fixed up this something over here, and that's why it's not allowing me to play my slides. But in the meanwhile, है ना, fixing करिए laptop की. आ गया. All right. But let me just go ahead. I do agree with one aspect of the previous talk when we said that if your patient is not fit, if the patient is old, debilitated, and you have no other option, you can go ahead with an intravitreal TPA. But that is a compromise. That is not an ideal situation. Now, given a choice, if you have got everything ready, what will be your preferred agent of choice? Will you like to go intravitreally or will you like to go subretinally? And what are the points? So these are a lot of cases where you do go ahead and try to use these cases, intravitreal or subretinal. The question over here is, given a choice, if your patient is absolutely fine, if you have got perfect amenities available, what would be your treatment of choice? And for me, the answer is pretty simple. It has always been a subretinal TPA. Now, there have been multiple studies which have tried to compare between these two. There are some which have come up with outcomes which are similar. There are some which have not been able to achieve a statistical significance, but what they have always shown is that while subretinal TPA was better, there was no statistical difference. But we are not talking of statistics, we are talking of patient outcomes. And why will you prefer subretinal TPA? Number one, this argument that giving subretinal TPA now is difficult is something which is not true anymore. With the advent of better vitrectomy systems, higher cut rates, vitrectomy is much more easier. With the advent of 38 and 40G needles, again, the ease of delivering subretinal TPA is much easier than what it was earlier. Second is, when you deliver subretinal TPA, you also facilitate a much more rapid and a quicker displacement of hemorrhage from the submacular space, something which anyways we are aiming for. Why do we use TPA? Why do we use displacement? The idea is to displace hemorrhage from the submacular space, and a subretinal delivery does it quicker and faster. The third and most important point is that I am still not very convinced about the penetration of intravitreal TPA into the subretinal space, and that is the most important limiting factor. Let me just give you one different analogy. Why is it now that we believe that brolucizumab is a better molecule as compared to the other anti-VEGF agents we have? And the reason is what we have over here, the molecular weight, 26 kilodalton. Smaller molecular weight allows for a better penetration. Tissue plasminogen activator, on the contrary, has a molecular weight of 70 to 90 kilodalton, and there have been studies which have shown that the penetration of TPA was not high into the subretinal space. Now, one fallacy of the only study that came was that they tried to basically alter the molecule by adding fluorescein to it so that they could assess it. But even after that, the size is 70 to 90 kilodalton, which then makes me slightly apprehensive about its absolute delivery into the subretinal space. So, a study of ability to penetrate retina, there have been studies which have tried to compare, and what they have shown is that it does not diffuse through intact neural retina to reach subretinal clots over here. So this is what one study which came way back in 2013 again showed that patient with subretinal TPA achieved a much larger reduction in final scar area as compared to intravitreal TPA agents. So this was one patient. This patient actually had been initially treated with intravitreal TPA when the patient came to us, and this is the outcome post subretinal TPA, and this is how the patient is finally. Visual acuity from 2250 has improved to 2040 in this patient. So if I do not have any other option, if my patient is not willing to tolerate anything, I may resort to intravitreal TPA. But given a choice, if I have an option, subretinal TPA is my agent of choice. Thank you.
Thank you, Mudit. My question to Shobhit sir is does it depend on the size of the submacular hemorrhage where you prefer to give an intravitreal or subretinal?
Well, like Mudit, I prefer subretinal. I use the cutoff point if the blood is more than 1000 thickness at the fovea, because I've seen in one of the published articles that as the cutoff point. If the thickness of the hemorrhage is more than 1000,
Not the size of the lesion.
no, not always the size, because if it's extrafoveal, what is the point? Yeah, so I think that is a very important point.
One of the questions that comes to my mind is there are studies about subretinal injection of air as well as saline that also can displace the blood. So is there a role of TPA really, or it's just the subretinal injection of the fluid that displaces the...
So the ideal thing is basically you are trying to displace the hemorrhage from the submacular space. But if it's an old hemorrhage, if it's not fresh, probably TPA does come into picture because plasmin will basically lyse the clot. And if it is not a fresh hemorrhage, then just a displacement will not be sufficient. You probably will need to resort to subretinal TPA. You are anyways injecting air as well as fluid. You have already created an entry point. Doesn't take more than 10 more seconds to inject 50 micrograms of TPA again.
I'm going to ask both of you one question. Would you do the same thing if it was sub-RP? And if you have a predominantly sub-RP hemorrhage, what will you do?
So while we believe that sub-RP hemorrhages will not respond as well, I have tried it in 3 or 4 cases and they have done better. I can show those images later on, but they have done better even with sub RP. Conventional teaching has always been, and what we have always believed it is that sub RP hemorrhages do not resolve that well. But these were patients which did. One of them was also a patient of PCV, and I actually ended up giving a Pagenex also post surgery. The patient is doing well. That was the only seeing eye of that patient actually. So there was no other option. We tried to do as aggressive a thing as possible.
I am absolutely agreeing with Dr. Modi that conventional teaching was not to give a sub RP injection because of the increased chance of systemic absorption of the TPA. But still, the sub RP hemorrhage goes beautifully, absolutely flat RP.
Sometimes there is complications like an iatrogenic macular hole following this subretinal TPA injections.
Subretinal TPA that you have to avoid within the arcade. You have to go beyond the arcade.
But your hemorrhage is within the arcade. How do you go beyond
as
the
far as fovea as possible, because you are increasing the subretinal volume, and the increasing subretinal volume will try to find a space from the weakest part of the neurosynergy, that is fovea. That will cause iatrogenic macular foveal break formation.
I think you had some studies regarding the size of the submacular hemorrhage and indication
I have already published it in IGO that is going to be released in, I think, in next month, in the May
4
or June.
disc diameter?
It is more than 4 disc diameter, you have to go for surgery. Less than subretinal blood. But less than 4 disc diameter, you can manage with other procedures like
the size as well as the thickness both matters.
Thickness, sir is telling, and Europeans are also doing a lot of study to secret. Yes, cutoff point is 1000 microns.
Thank you. So, yeah.
Your opinion. Anything else?
Predominantly sub RP hemorrhage. Would you use intravitreal or subretinal TPA? The same question.
If it is predominantly sub RP hemorrhage, then it may not help much. But if we have mixed blood, that is subretinal blood as well as sub RP blood, then definitely giving TPA and gas would help.
Thank you. So we move on to the next topic, steroid versus anti-VEGF in DME management. In favor of steroid, we have Dr. Purna Chandra. He is replacing Thirumalish in the last moment. He has a parallel session going on. So Thirumalish will be speaking in favor of steroids, and Dr. Siddhartha Ghosh will be speaking in favor of anti-VEGF in DME management.
So my debate will be with Dr. Thiru after the session. Just 10 minutes before he handed over the PPT and ran away. So I'm going to argue with him. But he had his valid reasons. He had a parallel session. He didn't know it was in this thing. If he had to present here, he had to literally swim back to his session. So anyway, let me just... Okay, so steroids in diabetic macular edema. We know the story of diabetic retinopathy and macular edema. 1 minute. Yes. So there's not a single factor which is involved in the pathogenesis of either retinopathy or the macular edema. There are multiple things. There VEGF is just one thing. Hyperglycemia, oxidative stress, vessel occlusions, external geogenesis, change in blood retinal barrier situation. There are multiple things. And to add to that, systemic factors also. So inflammation is one of the major factors in development of macular edema, and it's important to acknowledge its role in fluid accumulation, which occurs early in macular edema. So therefore, early treatment can control the inflammation and prevent the development of edema. Definitely, which we all believe that if you go by the definition of inflammation, that Ruber, Keller, Dollar, Functionalist, which we learned in secondary base, still it holds good here also. So we have multiple agents for DME management. You know, like you're all retina specialists. I need not go through these agents, the advantage and all. You all know better than me. So the points to consider whenever you manage diabetic macular edema is baseline visual acuity, of course, duration of macular edema, the ocular microenvironment, and the local pathological changes, example ERM or any associated factor. Is there any peripheral non-perfusion areas, lasered retina, non-lasered retina, and most importantly, the systemic factors, which we try to, sometimes we end up treating just the eye, but diabetic macular edema, we have to treat the whole person. So we know like we have variable treatment responsive to anti-VEGF, all of us agree. And steroid and laser proves to the presence of multitude of pathogenic, because you know like it acts in a broader way, like steroids, it's not limited to the specific pathway, which obviously will have some advantage. So if you go through the protocol T, the change in visual acuity, they claim that there was some around 18 letter to 15 to 18 letters of visual improvement. But the thing is, picture Abhi Baki hai dost, because that was seen only in 50% of patient, but rest 50% of patient they had only 7 to 8 letter gain. So this should not be forgotten. So that is one thing. And DEX implant in patients with treatment naive and all that, they have reported in the naive there was 12 letters improvement. In refractory cases, 8 letters improvement. We all can agree that 8 letter improvement in refractive and anti-VEGF, it's very difficult to achieve sometimes. So the BEVODEX study, which was done by Mark Gillis et al. I was my teacher when I was in Sydney from Safe Site Hospital. So they did not find any statistical. There was a difference. There was a better CMT reduction in the Ozodex group as compared to the anti-VEGF group, both the vision acuity and all. But this was not statistically significant. That I should acknowledge. But if you look at the gross data, the improvement in CMT and the vision was better in steroid group. So the DRCR net, they also reported the pseudophakic patient did well, and some of the patients who received initial triamcinolone who did well, maybe during follow-up the vision may not be good. The possible reason could be those patients could have developed cataract. So that could be the possible reason why a long-term patient had a lower vision in the steroid group. So that is one thing we need to focus. It's very important. We should focus in life, but we should not focus on one thing. We should look at a larger picture. So sometimes, like the take-home message is there is no current. We all agree that. I know I'm debating it as Subhendra sir rightly mentioned, some topics cannot be debated, but that Bagar Tiro, even I don't like arguing with people. And this is the consensus. There is no like a clear-cut indication like, okay, this is there, you give steroids. So we have our own individual opinions. So they are generally, steroids are regarded as a second-line agents for various, as of now, for resistant cases, but it can be tried as a primary agent also. So, however, treating anti-VEGF alone would be targeting the single pathway, as I already mentioned. And anti-VEGF, the cost factor is one more thing important. The moment I tell steroid, you need not imagine only the implant. There is intraocular triamcinolone acetonide also, which works equally better. And sometimes I have seen those crystals remaining in eyes for 6 months also. So it also kind of works like kind of an implant. So with watchful IOP monitoring, steroids are a good treatment option for treating diabetic macular edema. We should not narrow our mind, we should broaden our horizons. Sometimes we stick to one thing which we think as comfort zone. It's better to jump off from that thing. So the comfort zone which we assume may not actually be our comfort zone. So thank you so much.
Thank you. Let us first hear from Dr. Siddhartha, anti-VEGF in DME.
Yeah, good afternoon, and thank you, Aniruddha, for this opportunity. I think it was a lot of things have been said, and I think they are very well said by Dr. Purna. But in this debate of steroid versus anti-VEGF in DME management, I'm going to talk about role of anti-VEGF in DME management. And let us first go back to what Dr. Purna had started with, the pathogenesis of DME. If you look at this, it's a very busy slide, but as you can see, it's not working anyway. All the factors he mentioned actually leads to this particular thing. Whatever reasons, all the causes have finally lead to, even these inflammatory mediators, which is released as a response to hypoxia, all this leads to increased VEGF production. So the final common pathway is increased VEGF production, as you can see from the pathogenesis. And so we understand that is the issue. So vascular endothelial growth factor is the critical stimulus for diabetic macular edema. It has been researched and well published many times, and we know, all of us know about it. So what should be the treatment? Obvious choice should be, we need to target only the molecule that is the critical stimulus for DME. And as has been very well, researched, and a lot of very good trials have shown that if you compare with all the modalities of treatment, be it laser, the benchmark lasers, the steroids, and anti-VEGFs, yes, the best outcomes were always from steroids, and that is how all the landmark studies have shown. So we understand that multiple high-quality clinical trials have demonstrated that anti-VEGF is the therapy which is effective in vision-threatening center involving DME. Now, if you look at the guidelines, we are all practitioners, so we need to practice and take home something from this debate, what to really practice on. And the guidelines, all guidelines that we really follow, the Indian guidelines, the ICO, the PPP from AO, or what are the Retina guidelines, all the guidelines would tell us that intravitreal anti-VEGF is considered the gold standard treatment for center involving DME, while intravitreal steroids are established as a second line of treatment. So this is what the guidelines tell us. So I think let us not argue any further. And from these points, the pathogenesis, the high quality clinical trials and guidelines all tell us conclusively that anti-VEGF are the gold standard for treatment of DME. I just want to, since Dr. Pune has brought up this point, this was a publication, and as he said, that actually both gives, this meta-analysis was done. And if you go with the conclusion, overall intravitreal steroid and as a treatment for DME was associated with no significant difference in BCVA, but you should look at like what Dr. Aditya was saying, read in between the lines, and look at the second line. The certainty of evidence ranked from low to moderate. So we need to understand that, and the studies were not, it was limited by heterogeneity. So you really can't conclude. So what we need to focus is we need to target the pathogenesis, and if we really want to do that, anti-VEGF is the obvious first line of treatment for DME. Thank you.
Thank you, Dr. Ghosh. We don't have much time. Just one comment from Dr. Shobhit Chawla. Sir, steroid or anti-VEGF?
Well, where possible, I initiate the treatment with anti-VEGF as the literature and evidence says so, but where it is contraindicated, for me, contraindication to other risk factors, recent history of strokes, cardiac issues, I would initiate the treatment with steroids. Let's have Dr. Muna's opinion.
I think there are certain roles where I would give steroid as first line. Very thick macula, patient who's unwell, a recent CVA or a recent cardiac event or a bad renal disease, then I would
any
give.
biomarkers guiding?
Biomarkers have been studied. A lot of neurosensory detachment is believed to respond better. And we've seen that respond, and very thick maculas. Like we did a little retrospective study. It was a bit heterogeneous, but we found that patients where the thickness was over 700 anatomically seem to do better with steroid than. I wouldn't vouch on the clarity of data, but I think as a rule that would happen.
Ma'am, do you give any importance to hyper-reflective spots also, or it's only the neurosensory detachment and the thickness?
Not hyper-reflective dots, no, but neurosensory detachment and overall thickness of the macula. Most important, patient systemic status.
Thank you, ma'am. Let's move on to the last debate topic, micropulse laser versus conventional laser in CSR. Dr. Ajay Arora versus Shudipto Das.
So all good things come in the end. Micropulse laser. So I was actually I thought that my competitor would be talking on PDT or talking on drugs, but he's talking on...
PDT is not there, sir, no?
Yeah, no, but I thought he'd be talking on that or conventional laser. So he's talking on conventional laser, so the task becomes much more easier to me. You see how this was just a photograph taken 5 minutes back when Prashant was talking, and imagine my standing there. If I had conventional laser done, I would not see Prashant. So that's a paracentral scotoma we'll have if a normal laser is done. So, people have talked about imagine this patient being treated and you end up having a paracentral scotoma. You flatten the macula, but your field is restricted. If you do a continuous wave laser, we do in milliseconds, we reduce it, or we do it in microseconds. Until and unless it is micropulse, we will not be able to prevent damage. Either it is seen on an image, or on an angiogram, or on an OCT. And that is what is shown, that if you have a subthreshold continuous wave laser, you end up having an OCT documented damage, or you end up having a fluorescent angiography documented damage. The problem with micropulse is people believe that since we can't see, we don't know what is happening. So there was a study which was done by the Japanese group, which showed that on a lab, they could demonstrate the production of heat shock proteins, which showed that the micropulse laser is doing something there. We really do not know what, but it's probable, and you will see here carefully that after the micropulse laser, this was documented, and micropulse laser is working. So this is a patient who had a chronic CSR. He was treated with micropulse laser, and you can see the results for yourself. Patient did well. This was a dentist who had tried everything. He had had epineuron. He was having CSR for almost 5 years. And when I treated him in 2018, and now I have a follow-up of 5 years with him. So he has had 3 sessions of micropulse laser. In one eye, he had a secondary CNVM as well. We treated with aflibercept. The other eye, we treated with the micropulse, and the right eye, which had a CNVM, we treated him with micropulse after giving him Eylea. So this is what it was when he responded. So this is his eye, which was treated with micropulse. Within a week after the micropulse, you may have a little increase in the neurosensory detachment. Over the period of time, it settles down. Patient's visual acuity improves. This is this is the same patient. This is an ophthalmology resident who came to me. When he started his residency from close to Delhi, now he's finished the residency. He's had 3 episodes of micropulse laser treatment, and he has done well. So the take-home message is very simple. Would you like to be on a group like this? Is just to rest my case. Would you like to miss the images of the people you are seeing? Would you like to miss the beautiful image you have seen here? Or would I like to miss Prashant delivering his talk? No. So if that is what you want, then please go ahead with the conventional laser. Otherwise, micropulse laser is the way to go ahead. So normally our plan is that if a patient comes to us, we do not treat for about 6 to 8 weeks. If the patient is not responding, after that, I normally go ahead with micropulse because my experience has been very good. Almost about 98% of our cases do well with micropulse. It can be repeated and patients are doing well. And it can be, is much cheaper than PDT if at all it becomes available again. No dye injection is done. And Octa helps us to diagnose if there's a secondary CNVM, which we treat with Eylea and then follow it up with micropulse. Thank you.
Thank you, sir. Shudipto.
So I thank AIOC for this opportunity and Dr. Maiti for giving me this talk. So initially when I was giving the topic, I was thinking that probably it's because I have to speak in favor of PDT. Then he told, no, it's about conventional laser. So with very little evidence head to head, let's go and see what actually is there with conventional laser against this subthreshold laser. So CSR, we have these few points very important. There's a leakage of fluid. There is, it's a choroid dependent pathology. It recovers mostly with very favorable outcome, and chronic CSR can actually have irreversible vision loss in 5 to 15% of patients. So we have these available therapies: observation, thermal laser, mineralocorticoid inhibitors, subthreshold PDT. Any PDT is not available now, and others the other medical therapy. So conventional focal laser, this is a patient, we can see a very distinct leak which is being treated well with conventional laser FA guided. There was no scotoma for this patient. And when you actually see, mostly the treatment of choice was focal continuous wave laser before. The laser which targets the leakage points measured on FA and attempts to close the focal defect, as you can see by closing the blood retinal barrier. So laser should be limited to extrafoveal leakage, definitely. We are not allowing to have a vision loss, scotoma, or contrast sensitivity problem, or a CNV later. But there are studies which showed that SRF recurrence was nil when they have been treated with focal laser. And the complete resolution of an average, in these patients, of fluid was average a month. There were few reports of navigated laser FA guided, that also is there. So what is actually the advantage? Ease of doing this conventional focal laser. Well-defined leaks in early FA peaks. All extrafoveal leaks can be tackled separately. Hypopigmented spot, has been given in different literature, can also be picked up in this fundus photograph, and as well as in hypofluorescent, autofluorescent spots seen in patients with focal leakage. There are certain OCT findings also to find out these leakage points, such as presence of PD, photoreceptor outer segment layer thinning, dipping of the outer retinal layers, presence of subretinal fibrin, and RP irregularity. So there are a lot of guiding things to find out where from actually it's leaking. So these are patients having multifocal leakage, subretinal fibrin, did extremely well because all have extrafoveal leaks in multifocal CSF with focal laser treatment. This patient with again a leak with subretinal fibrin did extremely well with normal one focal laser. This patient had recurrence, but even in the first case as well as the second picture, you can see it was being treated with focal laser and did really well. So for all practical purposes, focal laser remains a viable and sometimes the only treatment option for patients with CSCR. These are the few studies where it has been seen in focal laser photocoagulation in an underrepresented population. 76% patients had complete fluid recovery, fluid resolution. 90% remained free from recurrence till the final follow-up of median around 8 months. So why to go with this very expensive instrument and increase the cost? So this was the randomized trial. This I have kept because this was randomized control trial with comparing PDT. So I've taken the arm of the patients who actually had subthreshold micropulse, and it was only 14 to 29% of cases who had a complete resolution of SRF in this RCT. But and if you can see in the picture here, a very nice extrafoveal leak which would have done nicely done a focal laser. If you do a PDT, actually you are doing this amount of area in the ICG. If you do some subthreshold laser, probably you are actually treating this amount of area. So probably you are complicating things. Now, if you see a long-term follow-up, after 20 months, patients treated with half-dose PDT are less likely to have recurrences compared to those. So probably subthreshold doesn't have that age. Even in increase in retinal sensitivity or microperimetry was higher in the PDT group. So STML, the subthreshold laser, targets RP. So I have a very basic question. How is it going to address the choroidal dysfunction in chronic CSCR? So this is our recent article on the evidence-based therapy guideline, where there was no large prospective RCT was there to compare the different protocol of these subthreshold lasers. Because we have varied protocols, we have different wavelength, makes it very difficult to compare the results of the studies and feasibility of using this subthreshold laser in CSCR. This is one RCT where compare subthreshold laser with normal focal laser, and they had a lower complete absorption of SRF in patients of subthreshold group compared to the conventional laser at 3 months. But both showed similar improvement of anatomy and retinal function at 6 months. Now, the subthreshold laser, they have repeated, thinking that probably RP damage was less, but power selection was an issue in this paper. So where to treat? I actually would ask Dr. Arora that, because I've not done for the subthreshold laser, but how to decide the test spot and how to reduce the target laser power, because we have different concentration of melanocytes in different part of the macula. Non-damaging, we need to have an endpoint management algorithm for this to treat. Complete area of FA leakage or ICG leakage or both, how to determine that, or we treat the whole hyper autofluorescent area. and whether we treat the nodal area of neurosensory detachment or the subretinal fluid. So the challenges, because there is a challenge regarding the area to treat, lack of treatment endpoint for visible retinal burn is a reason for under treatment which is being published, lack of standard parameters for subthreshold in treating CSCR, and various studies have used different duty cycles from 5 to 15% with a spot size 100 to 200 and power 90 to 1800 milliwatt. So it's not easy to titrate. So these are the probably the guidelines. I think Dr. Arora has already agreed that we usually do treat patients who are symptomatic, recurrent episodes, bilateral disease activity, and patient preference. But the choice, if it's not the PDT, then extrafoveal we do laser photocoagulation followed by subthreshold laser. So to conclude, if available, PDT is more convincing to treat CSCR. Conventional laser is relatively inexpensive and works beautifully in selected cases of CSCR and even in cases of exudate retinal detachment. Day to day, we still manage most of our CSCR patients with conventional laser. Standardization of the subthreshold therapy is needed, as the studies have utilized varying laser settings, differently selected target areas, and usage of multiple laser devices. Subthreshold is more useful in eyes with point leakage rather than diffuse area of leakage, so it may not replace PDT at all. And subthreshold complications are rare, but is it so very effective? I raise my case for this. Thank you so much.
Thank you, Shudipto. I think time is almost over. One last comment from our panelist, Madam.
Yeah, I think both have a role, definitely. Conventional laser done properly for a single small leak is as good, but subthreshold is an excellent alternative to PDT because we don't have it now. So I think we are using it more and more for certain cases where we cannot do focal laser. So I think each has more or less its own role.
Thank you. Before we leave, can we have our speakers, chairperson, and panelists for a group photo?